Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of inviting to the podcast Dr. Diletta Fumagalli and Dr. Gretchen Glaser. Diletta is at the European Institute of Oncology in Milan, Italy, and Gretchen is at the Mayo Clinic in the Division of Gynecologic Surgery in Rochester, Minnesota. And the reason for this podcast is the July lead article for our journal titled Rewinding the Clock on Positive Peritoneal Cytology in Endometrial Cancer. Does it predict prognosis in low-risk disease? So I'm really excited to have this discussion, and I'm very, very grateful to both Diletta and Gretchen for accepting our invitations, and of course, obviously, thanking them and the group of co-authors for submitting the article to our journal. So with that, Diletta, Gretchen, welcome and thank you.
Thank you. So excited to be here.
Yeah, thanks. It's great to be here.
Excellent. So we have lots of questions, and of course, obviously, a very pertinent topic to be discussing, particularly today in 2025 in gynecologic oncology. I wanted to start with Gretchen asking you, obviously, for a long time, we've routinely had performed peritoneal cytology at the start of every endometrial cancer case. Then there was some evidence that the results did not really impact management, and many of us had stopped doing cytology. So wanted to ask you why the renewed interest in this step, and why did you consider that this was an important study to conduct?
Yeah, thanks. Thanks for that question. So even though peritoneal cytology or positive peritoneal cytology was removed from the FIGO staging in 2009, and then in 2023, it maintains that it's of uncertain significance, the 2025 NCCN guidelines still use cytology for serous and clear cell in early stage to help guide adjuvant therapy. And so we know it's still a concern somewhere. And the question is it a concern in low risk patients? So there's just conflicting information about that. And we had renewed interest specifically because we felt that for low risk patients, this question was unanswered. When this question's been answered in the past, it's been sort of with everyone lumped together. Also, we had data. So at Mayo Clinic, we decided to keep getting cytology on patients because we kind of thought, I don't know, maybe it's going to be important at some point. It's probably good information to have. And so we kept collecting it. I remember having that discussion shortly after I started fellowship in 2010 as a group at the time, just discussing whether to keep doing it or not. So we had the information. So basically we wanted to know, we had the information, and so we wanted to look. And also just one other thing to mention is there's been a shift over these 22 years in how this surgery is done. So like 1999, we were still doing laparotomy, full pelvic and periaortic lymph nodes on every endometrial cancer. And now we're doing minimally invasive surgery, sentinel nodes. So we thought it would be pertinent to look back on it too and look at from that perspective.
Excellent. Great introduction. And I'll turn to Diletta now and ask you, with regards to the guidelines, what are the current recommendations by NCCN, by ESGO, as to whether peritoneal cytology should be part of routine staging in patients with endometrial cancer, particularly this low-risk population?
Yeah, of course. So first of all, as Dr. Glaser was reminding us, a positive cytology result does not impact staging. So it's not it was not part of the FIGO 2009 staging, and it's not part of the current 2023 staging system. The 2020 ESGO guidelines state that, quote, positive peritoneal cytology correlates with poorer outcomes, but they also report that its role remains unclear, and there is no guidance on whether to perform it or not. And on the other hand, the latest NCCN guidelines on uterine neoplasms still recommend that surgeons obtain the peritoneal cytology during all endometrial cancer staging procedures, since a positive result is an adverse prognostic factor, and that is also reported by the FIGO and AJCC. So the fact that positive peritoneal cytology is associated to worse outcomes has been reported. It is overall accepted, but there is actually no agreement on what to do next based on this result. So there's still a discussion ongoing.
Yeah, perfect. Yeah, I mean, again, it's as I listen to your answer, absolutely. I mean, it was something that, and again, we routinely perform, and then we kind of just fell out of routine practice in doing it, and thus perfect title for your article, Rewinding the Clock. So I'll turn to Gretchen now. What was the methodology for this study, and what were the inclusion criteria? If you can expand on those, that would be great.
Sure, yeah. So this was a retrospective cohort study. We looked at all consecutive patients who underwent surgical staging for endometrial cancer, apparent early stage, starting in 1999 and going to 2021. And these were all performed at Mayo Clinic in Rochester, Minnesota. So first we looked at a general cohort where we included all patients with low risk endometrial cancer, but then we decided to separate it into two cohorts. One according to NCCN guidelines and the other according to the ESCO, ESTRO, and ESP guidelines. And there was some overlap in these groups, but in broad strokes, the NCCN guideline included patients with grade 1 or 2, FIGO 2009 stage 1A. So because we had it all staged in that way, we left it that way. And then the second cohort was grade 1 to 2, 2009 stage 1A endometrial cancer. The only difference is these ones did not have LVSI. So there's basically a group that was all comers in terms of LVSI, and then a group with no LVSI. And then the peritoneal cytology was classified as plus or minus, so plus, positive or negative. One important thing to note is we did not include patients with isolated tumor cells. So because we know that those have an unknown prognosis at this point right now, obviously prospective studies ongoing. But yeah, so we excluded those patients.
Excellent. Yes, the prospective study, the Endo-ITC, certainly encourage all of you who are not familiar with it or who may potentially want to participate in the study to contact Gretchen as well and her team at the Mayo Clinic. So with that, then let's get on to the results, because we have lots of questions on these results. And I'll turn to Diletta. What are the results of the study? Main findings, an incredible number of patients, over 3,500 patients. What would you like to highlight?
Yes. So we decided to focus more on the low-risk cohorts that also Dr. Glaser described. So first of all, we found that positive peritoneal cytology was reported in approximately 8% of patients in both our low-risk cohorts. So both in the NCCN low-risk cohort and in the ESCO low-risk group. So it was definitely not common, but also not a super rare finding. Second, positive peritoneal cytology remained independently associated with recurrence in both low-risk groups, and that's also a very important finding. And we confirmed this even after adjusting for age, for lymphovascular space invasion, and for tumor grade. And we felt that these were very important confounders. So this was a major result. Regarding the survival analysis, the 5-year overall survival was not significantly different between patients with positive peritoneal cytology versus negative. But it's worth mentioning that we observed a significantly worse 5-year recurrence-free survival in patients with positive peritoneal cytology. And this was true across all cohorts, especially, the important result, of course, the low-risk cohorts.
Excellent. So now, regarding those results, we're going to get into some questions from our fellows. Diletta Fumagalli is a former fellow. and certainly very proud of the work that she's done since the fellowship. So with that, Gretchen, we'll turn to you for the first question. First question is from Natalia Tejeda in the Hospital Clinic de Barcelona. And she's asking, what criteria were used to indicate adjuvant treatment in this cohort of low-risk patients? And why did some patients with negative peritoneal cytology also receive adjuvant therapy?
You bring up an excellent point about adjuvant treatment in this cohort, and I have to say that this is one of the clear limitations of this study. Since the study collected information from patients over 22 years, there was understandably variability in post-surgical recommendations during that time frame. They changed. In broad strokes, the individual or cumulative presence of what's known as aggressive features like LVSI, deep myometrial invasion, or the presence of large tumors might have influenced adjuvant treatment recommendations. That was especially true in the early 2000s. And even going into the 2010s, things, started to change then, even in patients with a negative cytology. So in addition to the challenge of variability, the numbers of patients who received adjuvant therapy in this group, understandably as well, very low, given that they were low risk. And in this study, only less than 5% of patients had undergone any adjuvant therapy. So we have the challenges of variability and in treatment and of low numbers. But really great point, and definitely something we should look at in the future.
Okay. Now let's get a little bit into the reasons for positive cytology. And this next question, Diletta, comes from Luisa Prope, Hospital, University Hospital Münster. She's asking, the potential for hysteroscopy to cause significant dissemination of tumor cells remains an important topic. Do you have any information on whether these patients underwent hysteroscopy? And if so, how long before definitive surgical treatment was performed? Do you think this variable should be taken into account in the design of any future prospective study on this topic?
Yes, that's definitely very important. As Dr. Glaser mentioned, we have a study that included patients from a very broad time frame. So unfortunately, we do not have much information about the diagnostic workup of all the patients that are included. And also, for example, many patients have been referred to Mayo after a biopsy or a hysteroscopy that was performed somewhere else. And collecting these data could have been challenging. And there might also be a significant recall bias from patients. Even if we were able to contact all of them, still there might be recall bias. So in my opinion, it would be important. I would definitely recommend future investigators to collect this information prospectively.
Yeah. Another topic, of course, is on the surgical approach or surgical technique. And this question comes from Helena Obermeyer in Sydney, Australia. And Gretchen, she's asking, in your cohort, positive peritoneal cytology was more frequently observed in patients who underwent minimally invasive surgery compared to open surgery. What do you think might explain this difference? Do you think the use of a uterine manipulator could have been a contributing factor?
This is a really good point, especially because we've seen worse recurrence-free survival in patients with positive peritoneal cytology. So if, stands to reason, we want to think about how did it get there. So just to answer the question about manipulators, we actually do not use manipulators in our practice at Mayo Clinic. Rather, we use vaginal probes to perform the colpotomy, and these probes do not transverse the cervix. Of course, in a study near and dear to your heart, Pedro, in the LAC trial, and now in the follow-up ROC trial, there are measures being taken to maybe avoid peritoneal seeding with cervical cancer. So different tumor type, but similar idea in terms of approach. So there was another study published this year, a smaller study, looking at MIS versus open and peritoneal cytology, and they found no difference between the two. They also did not use manipulators, but they did suture the cervix before they did the surgery. So, that combined with the ROC trial makes me wonder, is that something we should look at in the future for endometrial cancer? Is it that we're not seeing recurrences because it's a longer lag time than cervical cancer? But do we need to do something to protect our peritoneum? I don't think this study gives us that information, but it definitely gives us a signal of something we could look at.
Yeah, excellent points. And I'll turn back to Diletta for this. And of course, we knew that this question was going to come up. This one is from Sofia Bigardi in Padua University Hospital. She mentions in the paper, Villager et al. Reported a positive peritoneal cytology that was more frequently observed in P53 abnormal endometrial cancers and was an independent predictor of recurrence and death within this group. Conversely, no association was found in MMR deficient or polymutated tumors. Considering this, do you believe your findings might primarily reflect the underlying molecular subtype distribution, and could this influence the potential reintegration of cytology into future risk models?
Yes, so this is a very good point, very, very interesting, and hopefully also the future direction of science. We need to add more information about the genomic and immunohistochemical features of these tumors, and this might explain why some patients that are considered low risk have positive peritoneal cytology, a higher risk of recurrence. And of course, the findings by Villiger and co-authors are confirmed by other studies. Yes, this might have a direct impact on future risk models, in my opinion. And for example, we could further stratify the recurrence risk also based on cytology taken together with other aggressive features. So the short answer is yes, but this has yet to be demonstrated in broader studies, in future studies.
Okay. And as a follow-up to that, Luisa Prope from University Hospital Munster asked, how might the study's conclusion change if molecular classification data were available and FIGO 2023 staging was used and integrated into the analysis of all patients, especially considering the heterogeneity of low-risk endometrial cancer? Gretchen?
Listen, it is definitely possible that low-risk patients with positive cytology in our cohort had other aggressive molecular features, such as abnormal PIK53 expression that we didn't account for because we didn't have the information. In the end, peritoneal cytology may just be a proxy for other aggressive features. It may be the best we have right now, or with the data from 1999 to 2021. But our preliminary results from the study you were both just discussing is not consistent with this hypothesis. And their analysis showed that patients with abnormal P53 and positive cytology had poorer results than people with just abnormal P53 alone, meaning P53 and negative cytology. So we need more information. We need more patients to have molecular testing so that we have bigger databases to look at. And I think that is going to be an important thing for institutions to combine so that we can get more information about that.
Excellent. So this next question gets us back to the topic of LVSI status. And Diletta, this question comes from Frederica Stroich in Heidelberg University Hospital. She's asking, the difference between both groups is the presence of LVSI in the tumor, and univariate analyses confirm LVSI as a risk factor for recurrence within 5 years in the NCCN group. Did you also examine specifically the group of patients with LVSI positive tumors to see, for example, whether they more frequently have positive peritoneal cytology? If this was not done, what was the reason?
Yes, we felt that LVSI was going to be important. Of course, we examined the rate of LVSI in the NCCN group, and overall 77 patients had LVSI. Patients with LVSI were the 3.9% of the cohort that had negative peritoneal cytology of course, within the NCCN low-risk group, while they were the 5.8% of the cohort that had positive peritoneal cytology, always, of course, within the same NCCN low-risk group. And this difference was not statistically significant. Also, it's true that LVSI was a risk factor for recurrence in the univariate analysis, but when we performed the multivariable analysis, the presence of LVSI was not independently associated with recurrence.
So, now, Gretchen, Natalia Tejeda, she's asking, did you all collect information on disease-specific survival? And if not, why not?
We were not able to collect disease-free survival because the cause of death was not always available. So the retrospective nature, we didn't always know why the patients had died. We also didn't know at the time of their last contact if they had disease or not. It just makes collecting disease-free survival in this situation very, very difficult. Some prospective studies, cancer registries, population-based studies that are able to look forward are much more able to collect disease-free survival or disease-specific survival. So that's what we would love to do in the future.
Yeah, absolutely. And often, yeah, the challenges of looking back on institutional data. So thank you for that answer. This next question, actually, Diletta, came from pretty much every single fellow. So we compiled it into this question. In your article, you note that positive peritoneal cytology was removed from the 2009 FIGO staging, and speculate whether, in light of the data presented here, future revisions of the 2023 FIGO classification might reintroduce this parameter as an indicator of increased tumor aggressiveness. Do you believe this could have practical implications for patient management, such as modified follow-up protocols or selection of adjuvant therapy? What steps would be required to change the clinical management of patients with positive peritoneal cytology? So yes, I'm sorry, it's a composite of many questions, but as a singular theme. So Diletta, your thoughts on that?
Yeah, of course. First of all, if or when positive peritoneal cytology is recognized as an aggressive feature, yes, I think this is going to have a huge impact. It could have, yes, it could have huge practical implications. But we also believe that our results will have a few practical implications. So patients come first, and they might benefit from this information. So, for example, a patient with positive cytology and otherwise low-risk disease needs to be aware that their recurrence risk increases, but also that their overall survival is not impacted, because also, I mean, this finding could be worrisome for some. And this could have a positive effect on them, in my opinion. For example, being accurate with surveillance programs without being too worried, too burdened about their chances to survive. And also, of course, there is the doctor's perspective. So, of course, it's important to note that we cannot draw conclusions now on adjuvant treatment recommendations, because we cannot do that based on retrospective studies. But we would like to continue studying the role of peritoneal cytology also in the context of molecularly classified tumors, and maybe one day also prospectively. So to change our clinical management, of course, we need good quality evidence, but not only that, we also need implementation studies to change or revert clinical practice. And so there's still a lot to do, a lot of research to be done, and that's actually great.
Excellent. So, Gretchen, I'll turn to you with regards to, again, the overall outcome being dependent on so many things other than cytology. And this next question is, given that there are many other factors besides the cytology status, and the fact that now we have effective treatments that we have for the recurrent setting, how are we to draw definitive conclusions from the results of this study?
I think the the definitive conclusion that we can draw from the results of this study is, but wait, there's more. That maybe peritoneal cytology should not be thrown out, that maybe we need to look at it as one of the aggressive features, that maybe we need to keep it in our back pocket as we molecularly explore endometrial cancer to determine what the interaction of that and molecular classification is. Similarly to how we're looking at LVSI in molecular classification or ITC in molecular classification. It's so important as we gain more knowledge to use all of the knowledge we have. And it's such a simple step to get some washings, to put some salt water in there before you start. So if I was peritoneal cytology, I would say, don't write me off yet.
Excellent. And Diletta, I'm going to ask you a question that, of course, it is maybe challenging in that, do you think the outcomes are different based on whether the cytology was positive from, say, an example, having a hysteroscopy or using a uterine manipulator versus when the cytology is positive because it is truly positive, that it is naturally positive and it wasn't induced by any of these other factors?
Yes, this is a tricky one. Of course, a positive peritoneal cytology result that occurs, let's say, naturally, might implicate that the cancer cells are able by themselves to disseminate, metastasize in the peritoneum. And one could think that from a biological standpoint, this is associated with more aggressive disease. But there is actually no proof that these cells are able to do so with a natural spread. So they are able to metastasize with a natural spread, but they are not able to produce secondary lesions if the spread is due to a surgical procedure. So this is very difficult to say to certain at the moment with the knowledge that we have. Evidence is also conflicting in the literature. So this is maybe another topic for future research. Why not?
Excellent. And I want to be respectful of both of your time. So I just have two more questions. This one for Gretchen. What do you see as the main limitations of this study?
Well, once a month, we have our Gynecologic Oncology fellows run a journal club with us. And one of the things we talk about early in the year is types of studies. And if we could design a perfect study, what it would look like. And I can tell you very clearly, it would not be a retrospective cohort study because it has limitations. So it's got selection bias and it is, got data missing sometimes. And I mean, we don't have more molecular data, for example. That's another thing. And we would love to know about P53 expression, et cetera. So that could be a confounder. So we also know that there were very few patients with adjuvant treatment. We wouldn't put that in our design study either. So I think all of these things can potentially cause problems, be weaknesses. But I think in general, it's a pretty diverse population, low risk patients. And I think we can just use it for what it is, which is a signal.
Excellent. So today we're very lucky, obviously, to have two representatives from major academic institutions, the Mayo Clinic and the European Institute of Oncology. So as typically, I will ask the authors, let's go to your practice. What do you do at each of your respective institutions as it pertains to obtaining peritoneal cytology? Do you do anything to prevent positive cytology in terms of adjusting your technique? And I'll start with Gretchen.
Yeah, great. So as I was saying, we do get peritoneal cytology at the beginning of our surgeries. In terms of preventing peritoneal cytology, one of the things we do is we make sure that we are not trying to get a uterus that is too big out of a vagina that is too small without putting it in a bag first. So we will use EndoCatch bags or Alexis bags up through the vagina, put the uterus in a bag, bring the bag out through the vagina, and then pull it down into the vagina to be able to get it out. And that just prevents seeding, prevents the tumor from being exposed. There's, we don't use manipulators. That started actually as a practice before all the data came out showing that, cytology positive from manipulators really didn't affect prognosis, but it's just carried on. So, you know, we all teach each other, and no one has started using manipulators after that. So I would say those are the main things that we do. Yeah, I think that's it.
All right. And Diletta?
Yeah, it's more or less the same, actually. So at the European Institute of Oncology, all the patients get the peritoneal cytology done at the beginning of the case. Also, uterine manipulators are not in use anymore. It's a bit different, maybe on hysteroscopies. So patients still get hysteroscopies also because sometimes they come and they already have a diagnosis. So it's already done. And yes, that's it.
Excellent. Well, Diletta, Gretchen, thank you so much to both of you. It's been really a lot of fun having this discussion. Again, very relevant topic, very timely. Very excited actually about our upcoming journal club, and I invite everyone who's listening to the podcast to join us for that, and there'll be announcements as to the date and time. Once again, congratulations to you, the co-authors. And really, again, congratulations for all that you're doing and contributing to the field of gynecologic oncology. You're both really important role models for our field, so thank you.
Thank you so much for having us. It was really, really fun.
Yeah, thanks a lot. It was really fun, a great experience.
Excellent.